Good morning, everyone. It's a pleasure to be here. I'm really delighted to share some of this work. I've been um, dutifully working on this INBRE pilot, as well as an INBRE Core Access Award. And the objective of both of the projects that I'm doing with these awards is to really understand clinical management of patients with both diabetes and social risk factors. So disclosures, I have no conflicts of interest, but both of these, all the projects that I'm going to discuss today are supported by the Delaware INBRE. So our agenda today, I'm going to discuss a little bit about diabetes and social determinants of health, as well as cost of care. And I'll discuss 3 ongoing studies supported by the Delaware INBRE. The first is focused on the collection of data on social determinants of health in Delaware. The second looks at the impact of social determinants of health on clinical decisions in diabetes care. And the third examines the association between care adjustments due to social determinants of health and diabetes outcomes. So Delaware has a ways to go in terms of our diabetes outcomes. Currently, we rank 41st out of 50 states in terms of our diabetes-related deaths. The cost of care for diabetes has risen dramatically over the past 2 decades, and this has led to difficulties for patients in affording their care. Diabetes differentially impacts patients with adverse social determinants of health, and these patients not only struggle with the cost of care, but also with other aspects of their management, and this leads to many adverse diabetes outcomes among patients with social determinants of health issues. Many patients, because they cannot afford their medications, have had to resort to protective measures such as insulin rationing, purchasing medications on Craigslist, going to Walmart and purchasing insulin over the counter without necessarily a physician or a healthcare provider's supervision. All of these are strategies to try and manage the cost of care, but also can adversely impact outcomes. The National Academy of Medicine, in response to this, has recommended that clinicians and healthcare providers adjust their care based on patients' social determinants of health. However, it's unclear whether physicians are currently engaging in this type of clinical adjustment. The American Diabetes Association, in their clinical practice guidelines published in 2019, they actually they mention and advocate for individualized approaches to care that really work with this concept of adjustment. You'll see at the top of this figure on the right that they recommend individualized targets for care. This particular object here is discussing the hemoglobin A1C target, and hemoglobin A1C is our metric of how good blood glucose control is over a 3-month time period for our patients with diabetes. The American Diabetes Association recommends that patients with resources, with difficulty accessing resources and difficulty with their support systems, they recommend that they actually have more or less stringent A1C targets, meaning we shouldn't be too focused on getting perfect blood glucose control in patients who are having issues with their resources. They also mention that for patients with limited life expectancy, we should be doing the same thing. And also for patients with risk factors for hypoglycemia, which is interesting, and I'll get to that in a later slide. Clinicians really should be adjusting their care based on social risk and other factors, but the question is, will they do that? And if they do, how will this impact diabetes outcomes among some of our most vulnerable patients? So to address some of these questions, I started 3 different studies to examine the influence of social determinants of health on clinical decision-making in diabetes care. These studies were funded by both INBRE Pilot Awards and also the Core Access Award. So our first question is, do healthcare providers in Delaware currently collect data on social determinants of health? To study this, as part of the INBRE pilot, I am currently performing a prospective survey study really focused on internal medicine, family medicine practices. The survey itself asks whether these practices are collecting data on social determinants of health and also how the practices are managing social determinants of health if patients are demonstrating that they have them. So the survey asks whether patients are assessed for social determinants of health, how the patients are assessed. Are they using systematic screening versus sort of an as-needed approach gathered in the medical history versus a validated screening tool? And then the survey asks how clinics address the social needs of patients. Are they referring to an in-house social worker or a community-based organization, or are they not providing referrals at all? I structured the questions in the survey around the social determinants of health categories defined in Healthy People 2020. As of now, so our most recent data poll was in a couple of days ago, and at that point we had 57 respondents with a total of 39 completed surveys and 18 incomplete surveys. We found that 100% of the practices collected data on at least one social determinant of health, and almost all collected data on more than one social determinant of health. This is our interim analysis that you can see, and our respondents by practice type, you can see that we had a sort of an evenish split between internal medicine and family practice so far in terms of our responses. And in our other category, you can see on the right-hand side, we had a number of other different clinics that identified as sort of infectious disease clinics, hospice, and med-peds, multi-specialty, and primary specialty. That's how they define themselves. You can see the median number of social determinants of health collected by practice type varied, but it was, between five and eight social determinants of health that were collected by practice type. In terms of our interim analysis of descriptive statistics for the social determinants collected, you can see that, I don't know why we have our x-axis going to 120% on percent collected, but on our x-axis we have the percent of practices that were collecting data on a specific social determinant of health, and on the y-axis you have each defined social determinant. So you can see that transportation, about half were collecting data on that. There's significant variability in a number of social determinants, such as food insecurity. So internal medicine practices, about 85% to 90% are collecting data on food insecurity, whereas, the other categories are collecting on food insecurity, whereas internal medicine is not collecting as frequently, while insurance, almost everyone is collecting that information. In terms of the methods for social determinants of health collection, the color-coded bars denote the method of collection, either in administrative paper form, EHR free text, or other. And you can again see some significant variability in how these social determinants are collected, the method by which they are collected. Regarding referral patterns by social determinant type, this graphic illustrates the proportion of practices that are providing referrals versus those that are not providing referrals based on the type of social determinant of health. Seems like pretty much all practices that are collecting data on transportation are providing some sort of referral, whereas patients that are describing issues related to education level or employment status or incarceration are not receiving referrals as readily. So in summary, social determinants of health appear to be collected by many, if not all, practices. But the methods of collection and the referral practices may vary by practice and by the specific social determinant of health being collected. There's an opportunity here to help standardize social determinants of health data collection and also referrals across practices. So our next study is going to examine how social determinants of health impact clinical decisions. Again, this is supported, by the INBRE pilot, and our research question is clinical decision-making among providers in diabetes care more heavily influenced by clinical or social risk factors for diabetes control? So really what I'm getting at here are, as we are collecting data on social determinants of health, as I described above, we see that most practices are collecting some data. How is this data factoring into clinical decision making? So are clinicians moved by social determinants of health when they are making clinical decisions for their patients? So not just referring to a community-based organization, but actually, are they changing the types of medications that they're prescribing? Are they changing the types of management that they're offering? And again, this is to some degree based on the National Academy of Medicine recommendations that we adjust our care, and also American Diabetes Association guidelines, which support adjustments in care, but don't give a clear path towards which decisions should be changed. So this is a cross-sectional survey study, and we're employing the use of clinical vignettes. Clinical vignettes have demonstrated similarity between actual standardized patient encounters in terms of their ability to demonstrate differences and patterns in care. A clinical vignette is a written passage that provides a clinical issue and then some sort of experimental component that's incorporated into that vignette to see if the experimental component changes management. And I'll get into that in a little bit. But a big part of this study was actually creating the clinical vignettes and piloting the clinical vignettes because they're the most complicated piece of this study. Our data source, so our intention is to administer this survey to primary care providers and endocrinologists in Delaware. The exposure that we are examining is a clinical issue compared to and in addition to a social risk factor. And we're seeing how that impacts medication selection and titration. Again, medications differ based on clinical effectiveness, cardiovascular protectiveness, cost, risk of hypoglycemia, many different issues. So we're really trying to see how these different components, the clinical risk factor and social risk factor, influence differences in medication choices. So the survey and vignette development, the clinical vignettes were developed by first identifying clinical and social triggers from clinical practice guidelines that specifically could prompt changes in care management decisions. So these represented sort of the baseline of the clinical vignette, that core component. The clinical risk factors that we chose included elevated A1C, which again is the measure of glucose control in a patient, the presence of cardiovascular disease, and also frailty. All of these clinical risk factors would be expected to shift a clinician's management decisions. The social risk factors, which again were the experimental component of the vignettes, included financial constraints, food insecurity, and insurance issues. We developed the clinical vignettes based on an iterative process that was informed by some key stakeholder feedback. And the final vignettes included 4 clinical cases, each of which had 2 variations based on specific social determinants of health. We included other survey components, including demographics, questions about personal experience with adverse social determinants of health and diabetes, practice characteristics for each of the respondents, as well as 2 validated scales to measure interpersonal reactivity and workplace stress. Interpersonal reactivity is a scale that's kind of similar to empathy and gives us a sense of how much providers might be in tune with their patients or affected by their social circumstances, because we thought that might actually impact their decision to adjust based on someone's social need. We included workplace stress to just get a sense of how busy these practices were and how much headspace providers might have to even think about these issues. If they work in an extremely stressful environment, they just might not be able to incorporate empathic thinking into their clinical decision making. The surveys were distributed by email through a REDCap survey to internal medicine and endocrinology clinicians, and the responses were collected and analyzed. I'm providing here a table shell to give you an idea of what the clinical vignette structure was like. So we have our cases in our column over here, and you can see that our first case, the clinical component was uncontrolled A1C. And then we had sort of a baseline case that demonstrated a patient with an uncontrolled A1C or uncontrolled blood sugar. Then we had a second case underneath that had the same exact clinical case, but noted that the patient disclosed homelessness. Then we had a third separate case, again with the same baseline clinical issue, same exact case, but the patient said they had no insurance. And we made sure to exclude homelessness when we talked about no insurance because we wanted to see the independent effect of each of these social determinants. Then we had a separate case. So our case number 2 demonstrated a patient with hypoglycemia. That's a very potentially serious complication that could result in hospitalization or even death. It's a trigger that we are very attuned to as clinicians. And again, we layered on these different components to that base case and made them independent components, food insecurity and cost constraints. We did the same for coronary artery disease. And then our fourth case, we actually had a stable clinical issue. So there was no specific clinical issue there. The patient was stable. They were under good glycemic control. There were no outstanding clinical components. And that was kind of our clinical control. And again, we then added on our social determinants. So this is sort of a control case, only looking at social determinants in our fourth case and not looking at any outstanding clinical issue. So we sent out our survey a couple of weeks ago, and this is our interim analysis. So far we have 39 respondents, and there's already some interesting information that's coming back. What we're looking at here, again, is it's the same chart as before, but we're looking at some of the data that's been filled in. So you'll see some variation in the responses that we've gotten so far. For our first case, someone with uncontrolled glycemia, so high blood glucose, you'll see that very few people chose to discontinue medications. And about the same proportion across the board agreed that they would add a non-insulin type of medication to these patients. And we found that among providers who would add insulin, we found that significantly fewer of them would add on insulin if the patient described homelessness. And this is really important because insulin needs to be refrigerated. So this demonstrates the fact that only 40% of providers would prescribe insulin to someone who is homeless. This demonstrates to me that they are picking up on this signal that homelessness is impacting their clinical decision making. And we found some similarly interesting findings across the board for all of these, for many of these issues. So I'm really interested to see what comes of the results of this study. Our goal is to survey 160 providers. Again, this is a really crazy time for many providers. We're trying to get as many responses as we can. So in summary, this interim analysis suggests that clinicians take social determinants into account when they're considering the clinical management of diabetes, even when the clinical status is stable. And there seems to be significant variability in care for specific conditions when social determinants are incorporated into the vignettes. So the goal of this study really is to validate these clinical vignettes through this pilot that we are currently doing with providers. We're going to take the information that we receive and then really refine the vignettes, make sure we truly understand what the triggers are for clinicians, refine the vignettes, and then hopefully incorporate them into a national survey that we hope to obtain funding for from the NIDDK. Our third research question is, how do these clinical decisions impact patient outcomes? So here we get into, we have demonstrated so far with our work that social determinants data is being collected. We've now seen in our interim analysis for our second study that these social determinants seem to impact clinical decision making. Now we have to think about, well, how do these clinical decisions, how do these adjustments in care impact outcomes? So this third project is sponsored by the INBRE Core Access Award. And our question is exposure to diabetes regimens with a high risk of hypoglycemia associated with the diagnosis of hypoglycemia among adults with Medicaid? So the background for this question is when considering the cost of care and different adjustments that are made, there are medications that are available that are very inexpensive, but they're associated with a higher risk of hypoglycemia. So we wanted to better understand among our at-risk patients, is the use of these types of medications associated with a higher risk of hypoglycemia? This could impact management in a couple of ways. So if we demonstrate among our neediest patients, among Medicaid populations, that the use of potentially high-risk medications actually does not result in a higher incidence of hypoglycemia, then we might feel more comfortable prescribing these types of medications for patients who can't afford them, who can't afford other types of medications. So clinicians are often limited in what they can prescribe to patients with financial constraints. If we feel more comfortable prescribing less expensive, potentially more risky medications, then we could potentially help treat patients who otherwise wouldn't be able to afford the more expensive types of medications. So this is a propensity-matched cohort using Delaware Medicaid data, and we are looking at patients in Delaware, adults who are 21 years of older with a diagnosis of diabetes. We use that 21-year cutoff because it's been shown that patients who are less than 21 years of age, some of them tend to fall into that type 1 diabetes category, and those patients are different in many ways from patients with type 2 diabetes. So we're trying to focus our analysis on patients with type 2 diabetes, or at least adults who have type 1 diabetes instead of the pediatric and adolescent population with type 1. The exposure is a medication regimen with a potentially high hypoglycemic risk. And these are defined by the American Diabetes Association as those that include a long-acting sulfonylurea or an intermediate-acting insulin. And the outcome is any diagnosis of hypoglycemia in the outpatient, emergency room, or inpatient setting. So I'm not allowed to share the data that we have gathered so far because it needs to be approved by the state before it can be shared. But what I can say is that we've already done our descriptive analysis, and what we found is that about 11% of the population of patients with diabetes in Delaware with Medicaid, about 11% of them use high-risk diabetes medications. A higher proportion, something like 30%, use the low-risk medications. So far in our analysis, we've found a fairly equivalent rate of hypoglycemia between those two patient groups, but we haven't done any real adjustment for any risk factors, and we are very much at the beginning of this study. But I just wanted to say that we do have a pretty considerable sample size, and we do have some basic descriptive statistics that we've gathered so far. So in summary, diabetes is an epidemic, and patients with social risk factors have an increased risk of adverse outcomes. It's currently recommended that clinicians adjust their care based on social determinants of health, Our current data from Delaware suggests that social determinants are collected, but with variability. And our interim analysis suggests that when presented with data on social determinants of health, clinicians do seem to alter their management. However, data is needed regarding safe, effective, and affordable treatment regimens for patients with social risk factors, as well as their associated outcomes. So I'd like to thank all of my collaborators, and I'm happy to answer any questions.